Now we're going to shift from the esophagus going a little further south to the stomach. And Dr. Mark Pimentel is going to tell us about abstracts. Mark is professor of medicine and director of the MASS program at Cedars-Sinai and an old friend and co-fellow.
Thanks so much, Gareth, and it's great to be back at this meeting. This is near and dear to my heart to be down here again. But we're going to talk about the stomach, which is not my usual subject, but definitely in our wheelhouse in the motility program. And let me see if I forward is this. Okay, got it. So I have no disclosures for this particular talk, but I have disclosures, as you just saw. Gastroparesis. What I like to talk about is sort of the physiology of the stomach. And at this year's DDW, as you can imagine, across the board, there was a reduction in the number of abstracts submitted in general. And that was even more poignant in the gastroparesis area, since there's so few people doing research in gastroparesis. But I'll take you through some physiology in order to set up what abstracts were quite notable and interesting at the meeting. So you've got post-surgical gastroparesis, you have idiopathic gastroparesis and diabetic gastroparesis. And one of the problems that we encounter with research in gastroparesis is we try to fit a round peg in a square hole, in that, you know, modalities for treating gastroparesis are applied across the spectrum of gastroparesis rather than picking patients who have idiopathic or who have diabetic or who have even iatrogenic. And so the problem is you get these obscure or very vague outcome measures. The other thing that happens in gastroparesis clinical trials for drugs, for example, is that often the wrong patients are in the trial, or patients who really don't have gastroparesis. I think talking to some of our motility experts, even at the meeting I just came from, it's amazing how many times a person with gastroparesis is referred to a tertiary care center, and we spend time saying you don't have gastroparesis rather than saying you do. And so if you have those patients in a trial who really don't have gastroparesis, but another reason for nausea and vomiting, that's going to screw up your trial. And so we want to get the physiology right, and we want to get the diagnosis correct. The symptoms of gastroparesis are nausea, vomiting, weight gain is actually what the Gastroparesis Consortium found, or at least higher body weight, which is ironic. And I'll show you an abstract that speaks to this. Early satiety and abdominal fullness, but it's a clinical diagnosis confirmed by a diagnostic test. It is not a diagnostic test confirmed by a clinical diagnosis. You have to have the clinical symptoms correct. If somebody's vomiting continuously on an empty stomach, it doesn't really necessarily mean they have gastroparesis, because often gastroparesis is paralysis of the stomach. It shouldn't be vomiting on an empty stomach because it doesn't move. So, and then there's a lot of other feedback mechanisms I mentioned at the bottom, including severe colonic inertia, which can result in delayed gastric emptying, but it's not the stomach that's misbehaving, it's the colon. I'm just trying to sort of give you like a seasoning of what we deal with in motility, and we have to be careful how we make this diagnosis. I've used this slide in the past, but it's really sort of poignant about diabetic gastroparesis and the complexity of the physiology, which I won't get into great detail here, but suffice to say, diabetic gastroparesis is a box. You get stuck in a box. You're hyperglycemic. Hyperglycemia tells the brain you have too much food, stop stomach emptying, don't keep emptying into the small bowel. So the stomach doesn't empty, but then it doesn't empty the drugs you've given the patient. And then the drugs empty later, and then the blood sugars are all over the place, and you're back to the beginning. And so diabetic gastroparesis is this feedback loop of problems. Now, maybe with some of the injectables, GLP-1 agonists and so forth, this box of diabetes is changing, and the physiology is changing because of these new therapies. But gastroparesis is moving more towards a physiology, and I'm putting this only as a marker to remind me to tell you that in idiopathic gastroparesis, loss of interstitial cells, which are the pacemaker cells of the stomach and the gastrointestinal tract, are reduced in some of these patients. Fibrosis is seen in the lining of some of these patients. And the Gastroparesis Consortium has made a lot of gains in trying to understand the actual cause of gastroparesis, which allows us to then move to treatments rather than just bombarding patients with drugs that the mechanism of which we're not quite clear are going to work. And then, of course, there's the iatrogenic, and we all know that if you hurt the vagus nerve, you you get pyloroplasm, or at least you get delayed gastric emptying. It's like the old vagotomy without a pyloroplasty. And so this is sort of iatrogenic gastroparesis and different. And often with repeated fundoplications or radiation for lymphoma, we see these patients, they're very difficult to treat, and you have to be mindful of this possibility. This is a study from 2019. I'm not going to show you the data because I'm going to show you what was presented at DDW, but it shows the Intera, which is an implantable stimulator. And this stimulator had great promise and maybe continues to have some degree of promise for gastroparesis. But again, herein lies the problem with gastroparesis. Put the right patients in the trial, you might get a good result. Put everybody who you think has gastroparesis in a trial, and it makes the water muddy. And a lot of the studies in this device have been muddy, even though they've showed some benefit. But the gastric pacemaker does not change gastric emptying per se. So it's not a gastric pacemaker, it is a gastric stimulator. And the other thing that they go on to say is that it is a vagal conditioner. Now, I want you to remember the two words vagal conditioner, because there is an abstract on vagal conditioning later. The cardiac pacing, I like to tell our cardiologists they have a simple job. Their heart beats after an electrical signal. The stomach has electrical signals and doesn't beat unless you need it. And so the stomach is way more interesting and complex than the heart. But here's a meta-analysis by Rick Saad looking at gastric electrical stimulation and all the studies over the years. The problem is, if you look at the top row on, didn't bring my glasses, but if you look at the top row, you can see these are, this is a short study, and then there's a 4-day study, then a 2-month study, then a 3 to 4 month study. So they're all combining short and long studies. And also each study has small numbers of patients. But all in all, there seems to be a clinical improvement with this if there isn't a gastric emptying improvement. And again, nausea and vomiting is improved in some patients with this device. So another thing that got into favor, this was back in the early 2000s, could we put Botox in the pylorus? And then there were publications of open label studies using Botox in the pylorus. And those open label studies said, wow, Botox in the pylorus, the stomach seemed to empty better and patients got better. Of course, until you do a double-blind randomized placebo-controlled trial and you see this trial in 2007, it didn't work. And again, it's selection for patients with gastroparesis. And maybe now with EndoFlip and other technologies for actually studying the pylorus better, we start to find the patients where this would work. And this led to GPOM for patients with pylorospasm or a tight pylorus resulting in delayed gastric emptying. And then laparoscopic and open pyloroplasty. But I really want to get to a meta-analysis here of pyloroplasty. And if you look at GPOM specifically, you can see this is an N of 332 patients. And this is going to get a little boring because the numbers are going to all be roughly the same. But if you do for somebody with gastric outlet obstruction having gastroparesis, about 75% of patients respond to GPOM. If you do surgical pyloroplasty, about 77% of people respond to GPOM. But these were open label studies. There is no sham study here. But what's interesting, again, in terms of selection, if you actually did Botox first, and the Botox made the patient feel better, which it doesn't do as often as you'd like. But in those patients had a better response or more likely to respond from pyloroplasty, whether it's open or laparoscopic or GPOM. So now we're into DDW, and you can see this is a meta-analysis and showing the pooled success a clinical success of using GPOM in the treatment of gastric emptying due to pylorospasm. And the pooled response rate is no different than what I showed you before. Now, if I go back, you'll see N of 11 studies in the GPOM group at the top. This was published in 2019. Now, during the pandemic, somebody wants to do it again, and it's 75.9, N of 11 studies. So it's really the same study that was already published, but reanalyzed by a different group. So not new, but being presented at DDW. Pooled analysis of gastric emptying shows that there is a response to gastric emptying because you are actually opening the exit of the stomach. And then this is the pooled analysis or meta-analysis of the side effects of GPOM. And you can see that it's roughly around 7% in terms of adverse events. In the meantime, again, the Gastroparesis Consortium and people like Jay Pasricha from Hopkins and others who are involved in this have been beginning to look at idiopathic gastroparesis, and maybe there are autoantibodies that are driving the immune response changes in the interstitial cells of Cajal of the stomach. And this is an interesting study using intravenous gamma globulin in 159 patients with gastroparesis. And 30.2% responded, quote unquote. And remember, response is improvement in symptoms subjectively, but it was combined with or without other therapies. So patients may have had gastric electrical stimulator or some other modality for treatment, but this was superimposed on what they were currently doing. Also, this is an open label study, so a little bit, you have to take this with a grain of salt, because a 30% response is about a placebo response as well. And you can see the graph is a little complicated because it shows the number or the length of IVIG treatment, and there were different lengths of treatment, and I guess they abandoned IVIG in some patients because it wasn't working. So I mentioned earlier that the Gastroparesis Consortium, one of the oddities of the gastroparesis database that they accumulated was that they were seeing that a lot of patients with gastroparesis had elevated body weight. Well, you could explain that maybe because diabetics or type 2 diabetics often are obese or have higher body mass index. So maybe that's the reason. But there are patients which we see in the hospital that have gastroparesis and they're very low body weight. So this study at DDW was looking at a lot of anthropomorphics, race, gender, and other factors that are associated with a database of gastroparesis patients. And they really were focused or interested in looking at BMI in this instance. And they looked at patients who were admitted to hospital to see if there was a predictor of patients with different factors and whether the outcome was worse. There was more obesity related to gastroparesis in women than men, more obesity related to gastroparesis in Black communities, and there was a higher comorbidity if gastroparesis was associated without obesity. So for example, there was less need for nutritional support. Patients did better, had a better outcome in hospital if they were slightly higher body weight, as opposed to the patients who were BMI of 18 or 16, some of the ones that we see. This is an abstract. This is actually from Jay Pasricha's group, and this is an interesting study because, again, trying to get to the root cause of gastroparesis, which is a very difficult thing because it's not a common condition, but they looked at the NIDDK gastroparesis database of 478 patients, and then they had a Michigan genomics database or initiative for gastroparesis with another 402 subjects, and they got 2 control groups as well. So large numbers. But the criticism here is for GWAS, large numbers means large numbers. So it may even be too small a study yet. However, they did identify a number of genes that appear to be linked to gastroparesis. And the genes, which I won't get into in great detail, often were linked to immune response, which we're talking about maybe gastroparesis has something to do with autoimmunity. Abnormal nerve conduction, which of course has something to do with gastroparesis, and smooth muscle contraction. So some of these genes do resonate with the phenotype of gastroparesis. But the data were weaker after excluding diabetics. So again, the power of the study is a little small for a GWAS study, but nevertheless, this is the beginning of a sort of a new era of trying to understand gastroparesis for real, rather than just describing it clinically. Delayed gastric emptying in Parkinson's is interesting because Parkinson's has forever been thought of as a neurological disease, a central nervous system disease. But in fact, in recent years, a lot of research has suggested that Parkinson's actually starts in the gut. And patients often describe decades of constipation in Parkinson's before Parkinson's ever develops. And now they're finding alpha-synuclein in the colonic tissue of patients with Parkinson's, even before there's alpha-synuclein deposition or believed deposition in the central nervous system. And then also there's evidence that the gut microbiome may be playing a role in this. This is work done at Harvard. And so Parkinson's may be a GI disease first, and then Parkinson's later, or what we know to be Parkinson's as the movement disorder. So this is a retrospective case control study from a retrospective electronic database, about 80 million people, and they used the ICD-10 code for Parkinson's disease, and the patients had to have been prescribed at least one Parkinson's medication. So ordinarily in databases and using ICD-10 codes, ICD-10 is a little tricky. It isn't for Parkinson's because it's a very unique diagnosis and a very specific diagnosis. And if you happen to be taking a Parkinson's med on top of that, you're pretty darn sure that patient has Parkinson's. And then they looked at, in propensity score matching, age, gender, race, ethnicity, and a number of comorbid conditions which had to be been diagnosed 2 years before the diagnosis of Parkinson's in order to look at this. And this is interesting, and obviously you cannot see all the numbers. This is the number of patients, 24,000 patients with Parkinson's, 19,000 patients with Alzheimer's as a positive control group, and another positive control group of cerebral vascular disease. But I'm gonna put some arrows where the interesting results are. Interestingly, in the time before the development of Parkinson's, IBS-C or constipation was a common diagnosis. And the theme here is not that it was IBS-C, but they had constipation. Functional dyspepsia was also a common diagnosis before the diagnosis of Parkinson's specifically, and gastroparesis. And gastroparesis was the strongest odds ratio. And the point here is that emphasizing maybe Parkinson's is, in the continuing building story, a GI disorder first, and what parts of the gut are affected, and could we use those as indicators of impending disease and maybe intervene early since we can detect this in the gut first. But not IBD, it's not present in Alzheimer's disease, and it's not present in cerebrovascular disease. So the point is, this is unique to Parkinson's. Then a few abstracts were presented on transauricular vagal nerve stimulation. So remember, I talked about the Intera, the device that stimulates the stomach. You implant this device for gastroparesis. Well, now they believe that part of the mechanism of that device is actually vagal conditioning. Well, you can get to the vagus nerve in a number of ways, and this is another way. There's a small branch of the vagus nerve which is located in the ear canal. And you can see that, I don't know if the mouse works, but focus on the green on the left panel, panel A, the green fibers, the yellow are not, and the red and blue are not. The green fibers are right in the middle of the ear, and stimulating that area maybe achieves the same thing rather than having to implant a pacemaker. That's the theory. The question is, does it work? And it's been studied in gastroparesis, but here I'm going to talk a little bit about non-ulcer dyspepsia in this abstract now. So this is a multi-center trial in China, randomizing patients to 3 different frequencies. One is the sham, of course, and the other is 10 hertz and 25 hertz. And the problem with this technology, as you'll see in another abstract, is they don't really know what frequency is going to work best. And the next one goes up to 80 hertz, and I'll show you that in a moment. They were stratified by H. pylori status just to get rid of that confounder. And the primary outcome was a proportion of patients whose FDSD score was greater than 5 after 4 weeks of treatment, and they had other secondary outcome measures. But I'll focus, if you focus on the right, this sort of summarizes the table on the left. But really 10 or 25 doesn't really matter. They had the percent of patients who met the primary endpoint or had adequate relief was higher in the group that got the stimulation. And so this may be another way of improving functional dyspepsia, maybe even gastroparesis, using a less invasive approach of, quote, vagal conditioning or vagal stimulation. The second abstract on this technology, this is a little more physiologic rather than clinical outcomes, so may not be as important, but this is looking at gastric emptying. So rather than functional dyspepsia, looking more at gastroparesis or gastric handling. So they did a water load test looking at what physiological changes. So normally with a water load test, what happens is that gastric contractions change. And if you had vagal conditioning, would those changes occur? And in short, it's basically if you just gave sham with the water load test, you did get a change or slowing of gastric pacing. If you had the device, the gastric contractions continued. So would that be better in gastroparesis? It remains to be determined, and more work needs to be done. But this is something that's coming because it's non-invasive and relatively easy to do. But there are a number of devices that are emerging in this area. So the last thing I wanted to end on in the last 5 minutes, according to my clock, is a little bit about bariatric surgery, weight loss, and what's coming. And because these are things that happened in and around DDW, not just at DDW. But if you compare in this study, this is a meta-analysis or a comparative study looking at body mass changes with Roux-Y gastric bypass versus gastric banding. I think we all know that Roux-Y is more successful at reducing weight and that it reduces fat mass more than just banding. But there's a similarity between sleeve gastrectomy and Roux-Y, and so hence sleeve gastrectomies have become popularized because they are as good as Roux-Y gastric bypass, or at least by this meta-analysis. There's a trend towards Roux-Y being better, but it doesn't reach statistical significance. So to summarize sort of the weight loss, and this is looking at all the studies in these meta-analyses, I put this table together. The Roux-Y gastric bypass gets you about 20 to 25 excess body weight loss. Sleeve gastrectomy, 26 to 32%, and gastric banding, of course, is lower, which is what I just showed you. So you're looking at between, if you look at the more common techniques, 25 to 35% weight loss. So that brings me to news that broke in and around DDW, which got a lot of media attention, and I wanted to bring it to your attention, is this. We know that GLP-1 agonists have been popularized as a way of weight loss, but now there's a GIP-GLP-1 receptor agonist combination. So just to remind you a little bit about GIP, because as gastroenterologists, you think GIP, gastrointestinal inhibitory peptide. However, it's been described that it really doesn't do a lot to the stomach as once thought, previously thought to reduce gastric emptying. Now GIP is not an inhibitory peptide, but rather is a primary function of increasing or reducing insulin secretion by the pancreas. GLP-1 is different. It enhances insulin secretion. It increases satiety, so makes you less hungry. And it is a very potent inhibitor of gastric emptying. So perhaps putting the two together will give you some benefit in terms of weight loss. And so this is not data from a study published. This was a top-line press release, but it got so much attention, and I want to put it in perspective of what we saw at DDW, which is the SURMOUNT-1 trial, which top-line results, 72-week phase 3 trial, once daily injection of this combination, and they got an average of 22.5% weight loss. So drugs are catching up to bariatrics, and the question is, when will this eclipse? And the question is, when will bariatric surgery not be required if these drugs continue to gain attention and gain success? And here you can see the percent of patients who had a greater than 5% weight loss was quite successful. This is the most successful obesity drug data that's ever been published or ever been presented to my knowledge. So something to be watchful for as this drug emerges. And then a couple of just random things. Duodenal eosinophils is an emerging area in functional dyspepsia, and I'm saying it's an emerging area, except there's a meta-analysis which a whole bunch of studies, so it's not like it's totally new, because there are a lot of studies in it. But there appears to be increased eosinophils in functional dyspepsia. And while I'm not here to talk about IBS or other functional disorders, eosinophils, mast cells, and other inflammatory mediators may be important in some of these other functional gastrointestinal diseases. So in summary, here's what I learned at DDW. If you have a year or two of COVID and you're a scientist, you do meta-analysis. There was a lot of meta-analyses. There was not a lot of new products, not a lot of new clinical trial data, because patients couldn't be enrolled in these trials. The causative mechanisms of gastroparesis are really important, and as they become or are elucidated, we'll start to have better treatments that are really mechanistic and picking the right patient, because the right patient will get you a better outcome. And devices and drugs are being used to manipulate gastric function, not just for treating gastroparesis, but perhaps optimistically treating obesity and other conditions. So thanks.
Thank you, Dr. Pimentel.